Blood pressure is a key piece of information for clinical diagnosis and treatment decisions. There are 27 factors that can impact the accuracy of blood pressure measurement. These factors can be related to what a person does before measurement, how the measurement is taken, and what devices are used. The time of day a measurement is taken also matters, as a person's blood pressure varies throughout the day. From waking in the morning to sleeping overnight, a person's activities and environment influence their blood pressure. So what can be done to get the most accurate and actionable blood pressure measurements? The steps to measuring accurately are to use the most accurate blood pressure measurement devices, use proper preparation, positioning, and technique, and to use a measurement protocol to take confirmatory or repeat measurements when needed.
Blood pressure measurement devices should be validated and calibrated. Validated devices have been tested for clinical accuracy using a specific protocol with the testing done by qualified independent measurement experts. There are lists that can be consulted to find available validated devices for purchase in the United States and internationally. Calibration involves assessing a device and its components to make sure everything is functioning properly. Calibration is often performed by a biomedical department or vendor. The frequency of calibration depends on the type of device. Blood pressure devices can be manual or automated. Automated devices take measurements with the push of a button. With these devices, calibration is less frequently needed. The person taking the measurement is able to focus on preparation and positioning, and the human error associated with measurements may be reduced. Certain types of automated devices can be programmed to take multiple blood pressure measurements and average the results with a single activation or push of a button. These devices are called Automated Office Blood Pressure, or AOBP. AOBP measurements can be taken with or without a clinician in the room, allowing flexibility to perform other tasks during the process. AOBP is the method of blood pressure measurement used in most major clinical trials, has been shown to be practical to implement in primary care, and may be the preferred method of blood pressure measurement in the outpatient setting. On the day of their appointment, patients should take their blood pressure medicine as they normally do. They should avoid exercising, eating a large meal, taking any caffeine, and smoking for at least 30 minutes before their appointment. When patients arrive, have them empty their bladder if needed. Once patients are ready to have their blood pressure measured, support their back by seating them in a straight-backed chair. Have them keep their legs uncrossed with both feet on the floor. If their feet do not reach, a step stool can be used. Patients should rest 3 to 5 minutes before the first measurement is taken. Cuffs that are too small or too large can lead to inaccurate results. To select the best cuff size, measure the circumference of the mid-upper arm. Many cuffs have range and index lines that can help make sure the cuff size is right. When the cuff is wrapped around the patient's arm, it should be snug, and the index line should fall inside of the range line. Remember, always place cuffs on patients' bare upper arms and make sure their arms are supported so that the cuff is at heart level. There should be no talking or texting while their blood pressure is being taken. Everyone who performs blood pressure measurements should have regular training, including competency checks, every 6 to 12 months to maintain best practices for measuring blood pressure. A measurement protocol creates consistency and standardizes the process so that every patient has their blood pressure measured the same way every time. A blood pressure measurement protocol should specify who will take the measurements, how many measurements will be taken, which blood pressure measurement devices will be used, and where the results will be documented. A nurse medical assistant, or other qualified healthcare professional should ideally take blood pressure measurements instead of a physician. This is because of the alerting response that occurs with blood pressure measurement and physicians. A patient's blood pressure rises about 12 millimeters of mercury higher when a physician enters the room compared to when a nurse enters the room. After about 10 minutes, the patient's blood pressure decreases, returning almost back to baseline in the presence of a nurse. With a physician's presence, it stays about 12 millimeters of mercury higher. It's also more typical for care team members to receive ongoing blood pressure measurement training and competency checks compared to physicians. Guidelines recommend taking multiple blood pressure measurements on multiple occasions. Blood pressure measurements taken on each occasion should be averaged. A practical approach to taking confirmatory or repeat measurements in primary care is to take additional measurements when an initial blood pressure is high. The rationale for this approach is that patients are often found to have a lower blood pressure when additional measurements are taken. Automated devices are preferred for all measurements because calibration is less frequently needed. The person taking the blood pressure can focus on preparation and positioning, and the human errors associated with measurement may be reduced. Each blood pressure result, as well as the average blood pressure results, should be documented in a structured field in the electronic health record. The measurement that should be used for decision-making needs to be clear to all members of the team, and notification of high results should occur. The implementation of a standardized measurement protocol, especially if it uses a new process or devices, can be a big change. A team-based approach to starting something new can help care teams feel engaged and supported.
Treatment for uncontrolled hypertension includes both lifestyle change and medication. Initiating and intensifying medication is an important strategy to improve blood pressure control, but too often, uncontrolled hypertension is not treated with enough urgency. A hesitation to prescribe, commonly known as therapeutic inertia, occurs. Contributors to therapeutic inertia include a lack of trust in blood pressure measurement results, a lack of familiarity with current guideline recommendations, and concerns expressed by patients around taking medication. The impact that medication treatment intensification can have on improving blood pressure control can be understood by reviewing a modeling study. Assuming a population-level blood pressure control rate of 46%, if adherence to medication at 1 year improved to 100%, blood pressure control would increase to 57%. If visit frequency increased to every week, the blood pressure control rate would improve to 68%. If medication treatment intensification were to occur at 2 out of every 3 visits when indicated, blood pressure control would improve to 80% or higher. So, what can be done to make sure patients receive timely and effective medication treatment for uncontrolled blood pressure? The steps to acting rapidly are to use combination therapy, ideally in a single pill combination, and to use a medication treatment protocol. Most patients with uncontrolled hypertension will need 2 or more medication classes to reach their blood pressure goal. Starting patients on more than one medication class at the time of diagnosis or adding a medication class when indicated gets patients to their BP goal quickly and effectively. Remember the 7-9-11 rule. If a patient is started on a single blood pressure medication at a low dose, on average, the expected drop in systolic blood pressure is approximately 7 millimeters of mercury. If that medication is then increased to a standard dose, an additional 2 millimeters of mercury, lowering on average, can be expected, bringing the total reduction to approximately 9 millimeters of mercury. If the medication dose is increased further to be high dose, on average, Another 2 millimeters of mercury systolic blood pressure reduction is expected, leading to a total reduction of approximately 11 millimeters of mercury. However, if an additional medication is added at a low dose, the expected drop in systolic blood pressure will be approximately 7 millimeters of mercury. In other words, adding a medication class has 3 times the blood pressure lowering effect compared to doubling the dose of an existing medication. Single pill combination medications make it easier to initiate and intensify therapy by combining multiple classes of medications. Many single pill combinations are available as generic formulations and are categorized as preferred drug classes by insurance plans. The classes used in single pill combinations are the same as those that have been routinely prescribed and shown to be safe for years. Lower doses can often be used, making the risk of adverse events lower. In studies comparing single pill combinations at low doses with single medication classes, there are no statistically significant differences observed in adverse drug events or medication discontinuation. Single pill combinations can also reduce the number of pills patients need to take and are associated with better adherence and better cardiovascular outcomes.
Partnering with patients means engaging patients in the self-management of their blood pressure. The steps to partnering with patients are to follow up frequently until blood pressure is controlled, use collaborative communication strategies, address medication adherence, support lifestyle change and stress reduction, and to use self-measured blood pressure. Following up every 2 to 4 weeks helps teams and patients monitor and manage blood pressure to quickly achieve control. Collaborative communication strategies can help customize the care plan for each patient. Examples of collaborative communication strategies include asking open-ended questions, using teachback to ensure understanding, and using positive reinforcement to encourage healthy ideas or behaviors. Ways to address medication adherence include medication counseling and education, including the use of medication reminders, providing 90-day refills, and solving any barriers or challenges a patient may face. Lifestyle changes that have been proven to lower blood pressure include weight loss, following a heart-healthy diet, reducing sodium intake, using potassium-based salt substitutes, reducing or abstaining from alcohol intake, engaging in regular physical activity, and reducing stress. Care teams play a key role in supporting patients to make sustainable lifestyle change by providing education and referring patients to available resources. Self-measured blood pressure, or SMBP, along with clinical support, has been shown to help improve blood pressure. This support may include patient education, telehealth, and medication management using standardized protocols. By using these strategies, care teams can engage and empower patients in the self-management of their blood pressure.